Welcome to Restoring Memory, a COVID calls exploration of the COVID-19 pandemic. This is a special COVID calls episode that is part of a longer series of the program that started March 15th at 5 p.m. Eastern Time, a deep dive into exploring and reflecting the first 2 years of the COVID-19 pandemic. My name is Jacob Steer-Williams. I'm a historian of epidemic disease and public health at the College of Charleston, and I'm so glad to be hosting a series of episodes for this special program. You can catch most of them. I was literally, before I jumped on here, I was listening to Scott's episode from the past hour with regular host and founder of COVID Calls, Scott Knowles. Scott began COVID Calls, a daily discussion of the pandemic with a diverse array of disaster experts, on March 16th, 2020. We're doing this marathon of episodes to mark the 500th episode of COVID Calls, which is an incredible testament to this public history project, to this digital archive, which is being launched. And for the record, this is episode 492, so we are super close. I feel like you get into single digits and something else is going on. So today on COVID Calls, I want to do a deep dive into COVID metaphors, into COVID history, into COVID research networks, and to COVID emotions, a big topic with some amazing guests. And what's so cool about this episode today and having these two guests on is not only are they both brilliant historians, but they're friends. So this one's really meaningful for me today as we end this part of COVID Calls, not ending COVID Calls, but maybe transitioning it into something new. So my first guest is Dr. Agnes Arnold Forster, who's a historian of medicine, healthcare, work, and emotions at the London School of Hygiene and Tropical Medicine. Her first book, The Cancer Problem, was published by Oxford University Press in 2021, a pandemic book in all of its illusions. We were just talking about that before the program. It's currently on my desk. Agnes is currently a co-PI on the project Healthy Skepticism, a Wellcome Trust and King's College funded multidisciplinary project about healthcare dissenters and anti-establishment voices. For several years before that, you may know if you're a listener of COVID Calls, she was part of the Surgery and Emotions Project. And a second monograph that she has coming out, so 2 pandemic book babies, which I need to process that. It's called Cold Hard Steel, The Surgical Stereotype Past and Present, coming out this year with Manchester University Press. Agnes, welcome back to the program.
Thanks so much for having me.
My second guest is Dr. Nathan Crow, who's an associate professor of history at the University of North Carolina, Wilmington. He's been expert on the history of 20th century biology, biotechnology, and biomedicine and Anglo-American scientific culture. His book, which is also on my desk, I didn't put their books on my desk today. I swear, like I have many right now, and their 2 just happen to be on there. Forgotten Clones, The Birth of Cloning and the Biological Revolution, charts the emergence of cloning techniques in cancer research after World War II and the complicated matrix of cloning science and cloning publics into the 1960s. Nathan is currently working on several projects related to understanding biotechnology. So welcome to the program, Nate.
It's good to be here, finally before number 500.
So I want to start somewhere that both of you will be familiar with, and probably a lot of the listeners to COVID Calls will be familiar with. I haven't heard anybody talk about this historical moment in terms of COVID, and I just want to sort of playfully start here. So I want to start in January of 1971, when American President Richard Nixon, in his State of the Union speech, declared a war on cancer. He implored that the time has come in America when the same kind of concentrated effort that split the atom and took man to the moon should be turned towards conquering this dread disease. He signed into law the National Cancer Center Act of 1971, which established the National Cancer Institute. But by the early 1970s, as both of you well know from your own work, neither war metaphors or explaining disease or cancer research networks were new. The rhetorical framing of Nixon's 1970s war on cancer holds importance probably only in its rhetorical framing, in its epistemological pushing of cancer as a metaphor for scientific work and for social ills. Today, of course, and I'm sort of thinking back to how I teach cancer, probably based on the research and publishing that both of you have done in my classes. Cancer still carries this kaleidoscope of meanings into 2022 and continuing through the COVID-19 pandemic. I was looking actually at the mortality and morbidity statistics for the last couple of years for the US, and cancer, of course, still is top 2. 2019 and 2020. In the past couple years during COVID, historians and the broader public have grasped to find analogy for understanding COVID-19. And we've turned to past pandemics. I think there's like a history of a history waiting to be written, like a meta history of how historians of medicine have tried to make an analogy to COVID using past pandemics. And I've been trying to think about what it means to even study that. We've turned to cholera, to plague, to flu, to polio, to tuberculosis, to HIV/AIDS, to Ebola. And each time I read one of these accounts by a colleague, I read them with interest, but then I'm also sort of lost at the end. I'm lost in the historical analogies. They keep falling short. And I keep thinking, especially in the run up to the 500th episode of COVID Calls, how to begin to historicize the first 2 years of the COVID-19 pandemic, and recognizing that historicizing is something that is ongoing, and it has to be ongoing as the pandemic continues to unfold and morph and change. But how are we going to fit this disease into our disease histories? I think that's like, as we sort of wrap up this to the 500th episode of COVID Calls, I think that's for me, and I think for my guests today, as historians of medicine and science, that has to be at the forefront as we continue, practices of teaching and public outreach and communicating to various publics. We have to find ways to make sense of this. So I've been thinking a lot about our failures, actually, as historians of medicine and public health, and how maybe we need to find new metaphors, to find new analogies, to find new frameworks to understanding COVID and fitting into COVID. So, I think one thing we've done really, really poorly is to try to box COVID into past pandemics that are temporally and geographically bound. So, COVID isn't cholera 1831. It's not influenza 1918, 1919. We like to bound those past experience in particular ways, but COVID is proving that we can't do that to explain the right now. So that has me thinking, and that's why I want to bring Agnes and Nathan on the program today. It has me thinking a lot about cancer, and cancer is so fascinating because cancer and cancer history is a murky history. Cancer framing historically and today, it has been one that hasn't been easy to categorize, has not been easy for the public to understand. Studying cancer, bounding cancer, appropriating cancer. Cancer seems to just fall only to metaphor. And I wonder if there's an interesting analogy there for COVID and for understanding our assumptions we've made about COVID and then thinking about COVID history. So I want to, that's the sort of jumping off point for our conversation today. And I want to start with just some basic, but some really deep question for Agnes and Nathan. And that is, you both have spent a long time studying cancer. And I wonder how you've been thinking about, and if cancer is a useful model for thinking about COVID and the history of COVID. What are the benefits of that, and what might be some of the limitations? Agnes, I'm going to start with you.
I suppose my answers are going to be a kind of collection of thoughts rather than anything really coherent or, a good sort of, I didn't have my line on this yet, I suppose, is what I'm trying to say. But obviously, if you are a historian of cancer, or indeed any kind of historian, or indeed, I suppose, a person that moves through the world in any capacity, you are likely familiar with the metaphors that surround cancer. And if you are a thinking person that moves through the world, you're also probably a little bit skeptical of some of those metaphors. And the shortcomings of those sorts of metaphors are in some ways really obvious, right? Is that the battle metaphor, the Nixon metaphor is problematic, not just on a kind of national sense, but also in an interpersonal sense. Individuals winning or losing a battle, a conflict with essentially an agency-free entity, is problematic to say the least. And so to suggest that we should use cancer as a metaphor for COVID, should set up a few alarm bells, right? It's obviously something that is potentially fraught with, the possibility of importing all of the things we don't like about cancer metaphors into COVID metaphors. But then, the other end of the spectrum, or at least a kind of another side to that conversation, is that humans are very bad at understanding things without some sort of recourse to metaphor. And especially things like cancer, you see this sometimes in critiques of cancer metaphors. You're saying, well, we should be talking about it only in medical terminology. only in stripped back, emotion-free language. But, that's also in some ways an impossibility, right? All language is imbued with metaphor, and especially, even the ostensibly value-free, emotion-free language of science and medicine is itself imbued with all of the kind of emotional baggage. These things are always descriptive enterprises, right? They're always kind of imaginative enterprises because we're talking about something that even on a kind of very clinical level is quite hard to comprehend. And the problem with cancer is that everyone knows is it's this huge, baggy, capacious category that collapses within it a million different types of illness. You can have a cancer that kills someone within 6 months. You can have a cancer that someone lives with for 15 years. And there aren't that many other disease categories, I would say, that have that huge diversity. You wouldn't call two diseases that are so different in experience, in symptomology, in outcome, in treatment programs or whatever the same term. And so to make sense of that in any way, we have to use some sort of analogy, some sort of metaphor. Even the word cancer, right, is almost itself an analogy or a metaphor. And I think that's one of the things maybe, so one, I think we should be cautious. I also don't know how you make sense of something as big and as scary and as complex as any disease, but especially cancer, without that sort of help, that sort of linguistic, rhetorical help. And I think that applies to COVID as well. There are so many obvious differences between COVID and cancer, not least in their biology, their pathology or whatever. But in terms of their capaciousness, their emotional import, and also their diversity, this is something I've been thinking a lot about with COVID. And it's one of the things that makes it a very difficult disease to talk about and to legislate about, is that it does have this hugely diverse, two people can be infected with this ostensibly the same virus and have incredibly different experiences of that virus, even if they're both, vaccinated with the same number of vaccines, they've been vaccinated with the same vaccine, that they're both sort of people in their 30s, the kind of classic easy patient, right? The 30-year-old healthy, whatever. And they can still have very different experiences, very different trajectories. One could get long COVID, one could not. Now, I had COVID over Christmas, and it really was a bad cold, and it was a pretty mild bad cold at that. But obviously, that's not the experience for everyone. And so, how do you make sense of something that is not just symptomology, in terms of symptomology, very different, but also in terms of its meaning for different people, its import, its impact, its kind of the sort of emotional baggage it carries is going to be very different for different people. The only way to make sense of that maybe is through metaphor. And that is something that it shares with cancer. The other thing I think that is perhaps, has the kind of commonality between the two, and this is, I think, increasingly part, obviously, of the COVID rhetoric, and we can talk about whether we think this is a good transition or not, but the sort of notion of COVID becoming part of life or becoming part of everyday life. Because cancer, even though it is in some ways the quintessentially sort of the superlative disease, right, in some senses, right, it is the disease you do not want to get, it's the disease that carries it, the closest associations, I think, with a diagnosis of death, wrongly in many cases, but that doesn't really matter in lots of these cases. That it's the bad disease, and yet it is also something that is quotidian. It is. We all will know someone who lives with, dies from, gets cancer, and likely at least one of us three will get it or will have had it at some point in our lives, maybe even two of us, or three. The way statistics work. But it's so sort of quotidian, and it's something that we do live with, and in some ways, COVID also tracks that because it is an incredibly serious illness. It has killed a huge number of people. But it is also something that we have had to live with, even if we disagree with some of the political framing of that living with, or the sort of political trajectory of some of that living with. It is nonetheless something that is part of our day-to-day lives and has been now. And I don't know about you, but sometimes I find it hard to remember or imagine a life before COVID. My life in many ways, although it has transformed in all sorts of ways, it has also continued in much. Your life continues. Under COVID in some form or another. And so that kind of living with disease as well as against disease, I think, is a big part of the COVID experience, the COVID sort of analysis, the COVID history, as it is the sort of cancer history. Don't know if any of that makes any sense, but
Yeah. Well, I know a few things, and then I'll have Nate jump in. One is that I think, like, I'm not sure, like, we can point to 71 in this rhetorical framing of a war on cancer and all of its problematic baggage as a, like, grasping at a model of cancer research and cancer mobility, but I don't know what the COVID metaphor is. I think we're still struggling with multiple metaphors for COVID, and those metaphors seem to me to all be politicized. I think that has been true of any kind of cultural framing of past pandemics too, or epidemics, or disease in general, including cancer. I mean, there's obvious political reasons why Nixon in January of 1971 makes that statement and starts NCI. But I think we haven't coalesced into any kind of singular rhetorical framing of COVID. I think we're still in this sort of divisive moment, particularly as so many people are just calling it over, as many parts of the world are putting their preventive policies aside in schools and in other institutions, in spite of what's happening in other parts of the world as the disease is yet again rising. So I think we're still grasping for what those metaphors are going to mean. So I want to maybe come back to that. But Nate, do you want to jump in with anything Agnes has said here, or have some different thoughts on cancer as?
Yeah, I have a couple things that I think a lot of what Agnes said was really compliments and made me think about a few things. One analogy that I kind of want to bring us back to that's similar to the war analogy, but was used really early on in the pandemic, is the Manhattan Project analogy that was really ripe with how we're developing vaccines, right? That was all these things that immediately came out was Manhattan Project style this, Manhattan Project style that. So in some sense, you could think about maybe breaking up the various iterations of the kind of history of COVID into different metaphors. Maybe there's not one that really connects them all, but we certainly have had ones that try to dominate certain discourses at certain times. And I you don't hear a Manhattan Project style discussion about COVID anymore, right? That's not the way. And historians have historians of the Cold War and really dislike the Manhattan Project whenever, because it's used so often, just like this kind of war on cancer, the same type of idea that we bring industry and people together and we all have one united effort, and it's kind of a bad understanding of what happened with the Manhattan Project and also like the ideas of what the outcomes are going to be. So I think that's an interesting one that we've just kind of like used, it flared, and then it's like gone away. And so now we're trying to like function with this replacement. I totally agree with this idea of the way we live with COVID and cancer. In some sense, just like we have with cancer stories, we all know people who have had it. We know, and every time somebody gets it, we can either regale them with people who have had it badly, and it's gone poorly, or ones that it was fine, they got some treatment, it was okay. And so I think there's just ways in which living with it also has these parallels with cancer. Both like we all, and some of us themselves have personal experiences, and so it's the same. Just like cancer, there's a kind of a statistical type of worldview, but there's also the personal story worldview that dominates everybody's like day-to-day relationship with the disease, which I think really does, and with cancer, dominate how people understand it. And just like some families have been devastated by cancer, some families have been devastated by COVID, and so and they treat it differently and think about it differently. It's interesting about metaphors too, is that, I think in our classrooms, at least I do in my classroom too, I often stand up and talk to students, being like, what do we think the use of history is? Why do we study it? And they always do this, like, history repeats itself. And and that's like historians nowadays say, like, that's the worst thing. That's not why we study history. Yet then when we go to publish our public history pieces, right, we immediately be like, this is just like the past. And and here again, I think that, as you say, the kind of metaphors don't sit well, because we actually, I think, in some sense, don't believe that these are ways in which we should understand our contemporary moment, is always to apply some sort of past analysis, because we kind of really truly understand that these contexts are so contingent and in their time and place. And so when we pull them out, it gets really muddy, and no matter what we do, and any type of situation. And so, people like to say the past rhymes, but even then it can get, out of rhythm pretty quick. And so I think there's that. The parallels, I think, there's some interesting parallels with cancer research too that I've thought about. And similar to the ways in which we sometimes really, and particularly in America, right, put forward a lot of effort into essentially the basic biology, right? I think Robin's book here, Robin Schiffler's book, talking about the kind of the biomedical establishment and this kind of, and the ways in which they like, well, we're not going to worry about, in some sense, preventative stuff. We're going to worry about like understanding the basic biology here and coming up with a cure. I think that kind of has this kind of parallel a little bit to the ways in which we kind of say we're not going to worry about the public health, some of the stuff so much, but we're going to focus on medicines and the basic biology of it, and that's how we're going to deal with it, rather than thinking about like what's in our water and what's causing cancer, right? What's getting rid of all these preventative things that can really cut down cancer. Instead, we think about like how can we make better treatments, or how can we make that's interesting. And the other one is that there is also in the long history of cancer a long kind of disinformation war, right? That also plays a role here. Thinking about, the really good parallel here would be cancer and smoking, and the link between that, and the way in which that was fought against and pushed back against, and the kind of how can you make these really strong connections between the two, and a public health establishment saying it's there, and enough ways in which that is kind of pushed against in a various cultural context. And the same thing with lots of, what's the rights of industry to pollute my, I live on a river that's highly polluted, and I have to like buy water because I don't want to worry about, all the PFASs. But of course that we have these issues with EPA and stuff. And these are cancer carcinogens. And so I think in some sense those are interesting parallels that I get with that, along with all the ways in which Agnes kind of articulated these living with and living within this disease. And one that also, I love this discussion about, we all have these, it's a minor cold for some people and it puts people in the hospital, and the others, and long COVID for others, it's still a disease that is, unknown in a lot of ways, just like we don't know the mechanisms for cancer.
Yeah. There's a continuum, right? And I'll share a very personal anecdotal story. So when our kids, we have 2 children, 7 and 3, went back to school in January. Like a week after the holiday return to school, my oldest son, like we got a note from his teacher saying like 7 out of the 14 kids turned positive in one day. And we were like, okay, pull out of school. And then like 24 hours later, he tested positive. And he is a otherwise healthy 7-year-old. He's vaccinated, he's boosted, and he showed like no symptoms. Like we couldn't recognize any symptoms. He never complained of anything. He just kept on with his full amount of energy. Obviously still worried about long COVID, and we just don't know a lot about long COVID in children. The rest of my family got infected, in spite of very serious efforts that I tried to keep my 7-year-old quarantined in our house, away from the rest of us. But my partner and I both got COVID, and our youngest son, who's 3, got COVID, who's not eligible to be vaccinated. He spent 3 nights not able to breathe, not sleeping. I was dreadfully afraid for his life. And his experience was not like the rest of ours experience. And we're in the same household, we're in the same familial unit. And that to me, like there's got to be some interesting metaphors for cancer there too, because, if we think about risk, and I've been thinking about risk a lot, and, there's a huge body of research on risk, and I think moving forward, because so many governments have given up on preventive public health, what basically governments have told us in 2022 in many, although not all parts of the world, certainly in America and in the UK right now, is that you're on your own in mitigating and navigating COVID. And what that's going to mean, I think there's an opportunity for public health officials not just to give up and despair, because what, public health officials I've been talking to and speaking with on COVID calls are like, that's not public health. Like what we're transitioning to is literally the opposite of public health. And I think there's an opportunity yet for public health officials to say, like, what we really need to be doing is educating everyday people on notions of risk. And it turns out, as you both know, there's enormous amount of research and public health messaging for other types of diseases and risk. Think about how we talk about, different types of cancers. And we don't do that uniformly with all types of cancers, but we do talk about the risk associated. The classic example is smoking and lung cancer, right? It's literally framed as, the beginnings of risk factor epidemiology in the 50s. And we talk a lot about risk and the development of different cancers. And I wonder if there's something there that at least public health authorities, but the broader public can start thinking about, as we move into, whether we like it or not, a different stage of the COVID-19 pandemic, where, as you said, Agnes, like living with it is something we're going to have to do, even though that's such a politicized phrase that like it sounds like fingernails on a chalkboard to me when people say living with COVID, but it's obviously true. But I think that phrase has been weaponized as a one to stand in to mean that COVID isn't serious. And I wonder if there's analogies here to cancer, because I think, I hear about, and I'm sure both of you have had too, experiences of friends and family and coworkers who get diagnosed with colorectal cancer or with liver cancer, and they die in 3 months. And other folks who get diagnosed with very different types of cancers who get treatment and recover, and so the cancer, the multiplicity of cancers and risk, I think is an interesting way to think about long COVID and continuing to deal with COVID, because we're going to have to navigate what that risk means to us differentially in our populations.
I mean, I do think there's so many things that you both said that I want to respond to, but I'll try and keep it succinct. But I think one of the things that's always struck me about talking about COVID, and this is a familiar truism, right, is that COVID hasn't created societal or problems in society when it comes to healthcare and medicine access and inequalities. It's just either exposed them and deepened them. It's deepened those sorts of pre-existing channels. And so our capacity to deal with, think with, cope with whatever COVID is incredibly dependent on how we have built ourselves up around other illnesses that we have lived with. And so I think with something like risk, there is a sophisticated literature on risk when it comes to cancer and a huge amount of research, but I'm not sure how well it has actually translated to, it is an incredibly difficult thing to communicate to people. And it is, I think, often there's a lot of research into, how certain things can override, that you're just using the word cancer in a diagnosis can prompt very extreme treatment pathways that are taken on by patients because it carries with it this particular threat that doesn't really tally to the actual risk or the sort of actual likelihood that person is going to die very shortly or get very ill very quickly. And it's very difficult to communicate something like smoking, I think, has probably made it the sort of the best transition to the public space. But the consumption of processed meat, for example, it's very difficult to communicate what the risk of, and it's also because it's quite hard to actually put your finger on, but it's very difficult to communicate the risk of something like that to eventual cancer outcome. And so I think our ability to communicate risk around COVID or to understand risk around COVID is sort of dependent on confusions or complications or complexities that already exist in the way that we talk about medicine and healthcare. But I did want to say something else about prevention and public health and all that kind of stuff, because I think that one of the other similarities that Nate was saying that reminded me of another thing that I think it's not so much a similarity between COVID and cancer, but a point of connection, which is exactly this thing, this sort of focus on the high tech of medicine. And the Manhattan Project of vaccine development, this huge emphasis. And this was, it's interesting you talking about the Manhattan Project, because as far as I know, that really wasn't a metaphor in the United Kingdom for sort of obvious reasons, right? But that didn't mean that we didn't have our own sort of, kind of very jingoistic kind of narratives around, the British AstraZeneca as an example. At one point our health secretary wanted to put the Union Jack flag on every vial of AstraZeneca that was sent out. It's all that kind of bizarre sort of scientific nationalism. And this huge kind of scientific project, this high science project, to really the detriment of, vaccines are great, right? We all love vaccines. Well, we all love vaccines, I assume. But they are only one part of a robust public health strategy or a robust preventative setup. And I think one of the things that has been, and I'm sure this is the case in the US as well, but I just know about the UK situation better. Cancer, the treatment of cancer, the diagnosis of cancer has really suffered as a result of the pandemic. That our healthcare system has really failed to keep up with some of its basic services, right? And cancer is a basic service or a fundamental service. And And, the things that have been difficult about the sort of delivery of cancer care has not been that we've got less good science over the last 2 years or less good chemotherapies. It's that we've got less good basic health services, like primary care physicians who have time to diagnose patients or to speak to patients, or we've got less good, our administrative structures have been messed up. All of that kind of low tech, but kind of fundamental sort of administrative tissue, I suppose, or connective tissue of a healthcare system that is, vital to the running of a healthcare system, they're vital to keeping people healthy or returning people to health, has been absolutely disrupted. And I think you can see a sort of parallel between, this sort of real emphasis on sort of technocratic developments or high scientific, investment really is done at the detriment of, quarantining, mask wearing, the kind of nuts and bolts of public health and the nuts and bolts of cancer prevention, even cancer care, have really fallen by the wayside. And I think that is, a fault of governments in terms of their investment in public health, but it's also, we all bear a certain degree of culpability in our kind of, romanticism and our sort of emotional investment in, the promises of magic bullets and the kind of mysticism of laboratory science. And I think, so that's another thing.
I mean, even to kind of connect it to the kind of health policies in the United States, I mean, that kind of discussion about primary care physicians, the CDC here in the United States tells people to kind of have risk assessment conversations with their primary care physicians. And, in America, lots of people don't because they don't have insurance or because for lots
you don't have a primary care physician.
Yeah, there's lots and lots of ways but that the ways in which there's an assumption that a connective tissue is there and they rely on it, yet it's not. And who has the best discussions about risk? It's probably those types of discussions, not being informed about individual risk can't be done by a talk show host, right? It needs to be done with somebody who knows your own personal medical history. And so, I think that's a really good thinking about, there's a risk thing, but there's no way to communicate that risk at an individual level in many of our healthcare systems.
Yeah. As a reminder, you're listening to COVID Calls. This is episode 492 of Restoring Memory. My guests today are Nathan Crow and Agnes Arnold Forster. So I want to talk a little bit about this laboratory question you bring up, Agnes, and real ways of studying laboratory biomedicine, but also some of the imaginaries of laboratory biomedicine, because it's something that I've been thinking a lot about and trying to understand. And so two ways to think about this. One is that in the first episode of this 500 run series, I guess 2 days ago on March 15th, Christos Linteris and Monica Green and I and Scott all chatted about origins and how to think about COVID-19 origins and is there a way to think about origins? And of course, we all said there's not, and any kind of way to pinpoint origin is a really faulty, kind of problematic way. Yes, there's a kind of biological reality that we need to understand spillover and epigenetics, and we need to understand SARS-CoV-2 in terms of its biology and evolutionary biology. But there's also this moment, of course, where at some point in early 2022, there's this new disease construction and it takes on new cultural meaning. And then that cultural meaning continues to change to where we are now. So origin is a fraught way to understand this. So that's one. But the other is, I keep asking myself, and Scott and I were talking about this the other day, I think anyone who's paying attention to COVID and who studies the history of science and medicine and biotech knows that studying the coronavirus family is not new. And there have been research teams all over the world studying coronaviruses and virology and vaccines from the 60s. And I keep asking myself, is that the history of COVID? The history of studying COVID-19 has to then draw a string back to the study of the family of coronaviruses. And something that I think is very simple. I mean, it's complicated, but it in terms of a historical exercise is something that I hope somebody starts doing, is just an institutional history of COVID research. And I think the other reason I wanted to have you both on here today is because cancer seems the obvious kind of metaphor and maybe it's not just a metaphor, maybe it's just a historical frame of methodology of how to begin thinking about if we want to like destroy the origin moment of the spillover, or maybe think more deeply about the origin moment of a biological spillover, human, animal, non-human, is thinking about these research networks going back. And I bring this up because I think there's a real institutional history that can help us understand this buildup to this like biotech arms race that we found ourselves in 2020 and into 2021. But also like if you following the cultural stories too, so here's where these like can mesh onto one another. If you're following the cultural origin story myths, there's still like huge fears about a lab leak. And those lab leak stories, if you're following them, there was a WHO investigation and report on this even, and a lot of them, you know, link a singular lab in Wuhan with a singular research team. And what this like trying to make sense of it to me is like there's all this popular and I think even in the scientific community, this like fear that the laboratory is this space of creation and it's this space of danger at the same time. And it's imbued with like this idea or this pedestal of scientific modernity, but then it's also imbued with this like this scientific occult that everyday people don't really understand too. And that seems to be completely wrapped into our COVID imaginings right now. So I'm wondering, Nathan, maybe let's start with you. Like your book really does chart the institutional research networks for cancer research. So how might we use that and not replicate it? Because I think like that's, as we talked previously, that's like maybe not what we can best do as historians. But how can the research into cancer, which like, as you show, studying cancer from the 30s, 40s, 50s, 60s, was a really complicated set of different fields having to come together, different people having to collaborate across fields and disciplines and across the world to try to make sense of not just the multiple meanings of cancer, but some of the basic biological research of nuclear transplantation. So I'm wondering like how your research fits in with studying COVID and drawing a longer line back maybe to the 60s. Does that make sense?
Yeah, it does. You know, and two things too. I want to kind of pop in. I feel like I haven't heard much about this, and maybe it's because I haven't seen it. But you know, I can't believe that more people haven't talked a little bit with the lab leak theory about that. The event that happened, I want to say in 2012, when remember there was a fairly large worldwide uproar when researchers, I feel like in the Netherlands, maybe created a flu that was airborne using what was it? You know, a certain lab animal, right? And they were talking about, and then there was a huge kind of question about whether or not that should be published because they didn't want people to be able to replicate it because it could lead to a pandemic. And so there very much was this, a lab has created a kind of very bad flu virus that could be used as a bioweapon. And then there was questions about whether or not that should be allowed to be published. And then there was lots of discussion about censorship. So these questions about modernity in labs and what they're doing in labs and creating, it's certainly there. And I think you could probably trace that back to anthrax and a bunch of other ways in which we think about kind of bioweapons and stuff. So there's that kind of connected to the Wuhan thing, but and it's not like an ancient memory, but rather one that's something we dealt with rather recently. As far as research networks, you know, one thing that I, you know, really found interesting about my book is or when I was doing my research in cancer institutions and cancer research is that, you know, it brings together lots of different types of people, and often with very different goals. You know, the group that I was looking at, we're trying to say in the 30s and that the best way to understand cancer was through understanding the kind of the normal process of growth, right? Which was at that time considered not the way if you're not working with humans, right? And studying, understanding how to treat humans and how to understand cancer in humans, what are you really doing, right? And they're like working on pea plants and pea shoots and onion roots, right? To think about how does growth work? Because obviously there's some sort of growth gone wrong. And that led to lots of different types of interesting questions. So nuclear transplantation was just trying to figure out, well, what is controlling development? Is the nucleus or is it the cytoplasm, right? And out of that, you get cloning technologies that emerge from it. And from then, they kind of move on into their own spaces, right? And their own research networks develop. And the kind of connection to cancer is kind of forgotten and it overlooked. And it becomes not part of the genesis of the research, but rather happen to be where they are. And so But what it does remind me is that, lots of people may be using coronaviruses, right, on lots of different ways, and not in the places we might see them. And I think that would, if I was in a, talk to a graduate student who was really interested in this type of doing a research like this, I would say, don't get connected, or don't get kind of, don't try to look for all these people who were, in the 60s and 70s being like, this is going to be a bad virus one day. Don't get kind of swept into the idea that the pandemic is the immediate outcome eventually, right? And that we need to trace this history with the pandemic emerging with always in the hindsight, but rather try to look at it in the ways in which it might have gone in lots of different directions, and people doing very different types of research. And it might not, elucidate this idea that it was always going to be a pandemic, right? I think that's what sometimes we can get really connected when we go back to these major biotech moments that are contemporary. We go back and draw that string straight to them through the labs, through the institutions, and that ends up leaving out a lot of different other ways in which it was researched and used and thought about. And so that would be one thing that I would try to my first thing is let's go back and find out where are all the places that it's sitting, right, and doing and connected to that are not people who think it's going to be a pandemic, or doesn't really lead to, say, vaccines or something to that effect. Yeah. But that's
a deep history instead of a linear history.
Yeah, it's not. I think when we draw these linear histories, we lose a lot of the questions that people were asking about coronavirus, because you would always say, how does coronavirus become a pandemic, or what were people thinking about it? And you, of course, will find people who will say that, right, in grant applications, and will tell, and institutions that say they want to do that. But then you're probably missing all of these other type of evolutionary questions, all these other type of just basic common cold questions, all sorts of immunology questions that people were not worried about a pandemic, right? Or we're not worried about these things. We're very much interested in zoology questions, and it wasn't always about spillover and pandemics, right? Lots of but lots of other types of questions. And if we just draw that one line, we lose all those questions about who's working on coronaviruses.
Yeah. No, I mean, I think somebody needs to start applying for 5-year ERCs on this topic, because I think it really is fruitful. But I'm wondering, based on what you're saying, there's a fulcrum here too, because in a way, I think if you look at the moment in the early months of 2020, what you see is, I think, a crashing maybe of what the coronavirus family had meant to both scientists, to the scientific community, and in popular culture, because before early 2020, probably very few people out of scientific networks of studying the coronavirus family could even had ever heard of that term coronavirus, right? But of course, the majority of coronaviruses that cause sickness in humans include varieties of the common cold, things that people have already gotten in their life. And so if you think about this moment in the first few months of 2020, when there was this thing, SARS-CoV-2, there were so many people just calling it just like the common cold. And that's because of this, even though everyday people didn't even know what the word coronavirus meant, or that some of the coronavirus's family were actually causes of the common cold. I think that somehow did translate from the scientific community very, very quickly. Because I bet you could go back and find reports from March and April of 2022, where in everyday news reports describing what this new mutated virus was, they said, oh, the family of coronaviruses, some of which cause the common cold. That can lead, as we know as historians, in really quick, indelible ways to deep cultural meaning. And I wonder if that's so in order to understand this, this set of origin stories over COVID-19 and our response to it, and honestly, now where we have gotten today and might continue to go, part of it is that deeper history of coronavirus inflects how we responded to its immediacy. So that's maybe one side. The other side of the fulcrum, of course, is going back to the tech solution. So the emergence of COVID-19 vaccines by late 2020 and into 2021 was 100% because scientists had been studying coronaviruses for so long. The vaccine technology depended on studying, previous strains and mutations of COVID-19. So there's real scientific progress, I think, that we'll look back and see as a result of this deeper history of coronaviruses, but then also this inflection of COVID denialism because of that very same thing. Agnes, you want to weigh in on any of that?
Yeah, loads of it. And I mean, one thing I would say this quickly about this idea that certain assumptions about a disease or aspects that are essentially true about an illness or are true in some ways that then can move with incredible speed and then become incredibly enduring in terms of like popular perceptions of an illness. I think that there's something in there when I have looked at my book is about the 19th century and cancer's sort of associations with or assumptions that cancer is contagious in some way. At one point in its history, and it is also partly true about some cancers, and at some point in its history, there was a sort of almost a consensus that there was a sort of potential contagious element of cancer. Mm-hmm. But one of the things that I think is very telling about something like that, and I suppose also very telling about metaphors and analogies, is that these things can bed into people's minds and stay there for generations, that people can hold on to these ideas even if they know they aren't true. And I think that's some of the sort of really difficult things about an illness like cancer and an illness about COVID. I mean, I suppose any illness could have this sort of identity, but that it doesn't need to be totally scientifically accurate for it to have purchase and for it to sort of stay in the ether for a really long time. I suppose one of the things I was listening to you guys talk, I was thinking about, I read for my sins, I don't really know why I do this to myself, but I read 2 books about COVID kind of recently. One is Spike by Jeremy Farrar, who runs the Wellcome Trust, and one is called Vaxxers, which is written by the 2 women who developed the AstraZeneca vaccine. And they are really interesting books to read as a pair, and I think provide really interesting and very different models for how you might write a kind of institutional history of COVID. Because Spike is written by a powerful player in the kind of global health landscape. He's sort of very influential. He's got his fingers in loads of pies. Is very friends with all of the he's constantly name dropping like big political figures and the director of the WHO and all this kind of stuff. And it really reads like a thriller. It reads like a kind of political intrigue. There's all these sorts of like complicated power plays and the sort of Chinese reluctance to release data. All of this kind of stuff. It's a fascinating book. I mean, it's an interesting book. It's a readable book, but it's also just fascinating if you're interested in like how you write a kind of political history of disease, because it has all of the elements of a spy thriller, of a drama. And then Vaxxers is at the other end of the spectrum, is a kind of deeply quotidian tale of how is the business of science done? How is laboratory science actually carried out on a day-to-day basis? They talk about their childcare demands, their commutes. They talk about getting to the laboratory. They talk about what it means to pipette something. They talk about all the different people involved in the process, from the Oxford professors right the way through to the lab cleaners. And it's a kind of deeply it's sort of a social history, I suppose, of lab science. Obviously we need both of those histories, right? We don't necessarily need the spy thriller style, but we need those sorts of histories of institutions that both attend to the place of COVID in these big geopolitical conflicts and, the sort of cold wars of, I mean, don't want to talk about Cold War right now because it seems to be rearing its ugly head, but, you need to see that sort of big political machinations that happened around and in and, inflected the way that COVID was thought and felt about and dealt with. And then also you need that, like, how do these, this is a sort of history that appeals to me, I suppose, just sort of personally, is that like, I'm not so interested in, the technocratic achievements of big science or biomedicine or whatever, but I am interested in how scientists do their work and think about their work and how do you, when you talk about like, something like Spillo, these sorts of moments or inventions or developments or the development of a new drug or whatever, like how are they actually done and who are the people involved in making those things happen? That is so interesting to me. And I think that any history of COVID is going to have to reckon with all of that and going to have to reckon, properly, so that we don't recreate, I suppose, the mistakes of historians of science and medicine past that just talk about, the big players. We want to have all of that texture in there as well as all of the drama.
Yeah, thanks for that. As a reminder, you're listening to COVID Calls, episode 492, Restoring Memory. So I want to end with our last 10 minutes here and ask a personal question of you both, and probably an unfair one. So navigate the question as you see fit. But I wonder, because I think about this a lot, is what has it meant to you? I mean, you're two like amazing scholars who study medicine and biotechnology and health and surgery and emotions, and I mean, you study this like I do, and what has it meant to you to study the kind of things you study and that you're an expert on and that you continue to publish on? I mean, you both have written books and published them in the pandemic. What does it mean to continue to do this kind of work, given the circumstances that we faced in the last 2 years? Sorry.
I mean, I can, since I'm unmuted already, I'll go. But I do think it only continues sometimes. My first thought is that it continues, or maybe has even made the question that we've all dealt with even since graduate school, right? About like, what are we doing here sometimes? Like, what are we doing in this profession? So, and we have these conversations with, this is a great conversation, but I feel like it's, it's not reaching my parents and it's not reaching my, like the kind of the day-to-day people people I play soccer with or whatever, like doesn't really, none of this reaches with them. And the types of work I do seems so sometimes hyper-focused because like, Agnes, I'm really interested in how people made those things work and I wrote about them. But then yet we're here dealing with these huge problems that I feel like in some sense, like I feel like, when I'm trying to write, when all of these big things happening, it feels so tiny, right? And I think that's a kind of an issue that scholars always have. But over the past 2 years, when it seems like we're just dealing with such global threats and it's such challenges to kind of living life that, it makes it difficult. It makes it more difficult. And, the sad thing is, plenty of scholars have been, I'm very privileged scholar that I haven't had to deal with many of these issues until now, right? I grew up in a perfectly kind of middle-class household. And so I didn't have to worry about food insecurity as a kid. So like that challenge, it's a different type of thing. And so there's just a challenge sometimes, I think, keeping on, I think for me, what are my research questions and how do they matter? Always is there. And that way, I feel like my teaching has continued to save me, right? And thinking about that keeps me going very easily because I feel like I really can make a difference there. And I can bring the insights that in here, but like there are always big questions. I think about what Agnes just said about the types of histories we need to tell COVID and stuff. And it's like, well, how do I do both of that in the classroom? Because it's really difficult. But yeah, I mean, this is what, for me, my first thought is sometimes it's maybe even change your trajectory a little bit of like what questions I'm going to ask next in my research. Maybe they're a bit bigger. Maybe they're a little less confined to the small number of people that or the kind of my natural segues into something that's really kind of small. But that's a first pass at that difficult question.
Yeah, and and I wonder, a few things. So I started, at the outset of this saying like how much I think historians of medicine and public health have kind of failed to materialize and mobilize a kind of like really coherent historical framing of COVID. But I'll say the other side of that, and like in all honesty, those failings are like self failings of my own too. I include myself in those. But also like I've never been more proud of historians in the last 2 years who've gotten out there, who have put themselves out there, who've actually like tried to demand that the history of medicine and public health and science actually has a seat at the table in policy decisions and in helping people cope and in helping people understand. And I think, and I hope that we can have as a field more conversations about that and mobilize it in real ways to try to reestablish the values of what history is and what history can do. Because I think there's this 500 episodes of COVID calls, I think, is an example of that too. That, I don't even know how to process, but it's reached hundreds of thousands of people every episode and spoken to hundreds of people. And I'm, as much as I think, like, if I really try to epistemologically think about, have we succeeded in any way in making sense of COVID? Probably not. But have we succeeded in demanding that the history of medicine and public health and science matters now? yeah, I do think we've succeeded in that in some really deep ways. So I hope that we can, have more conversations and mobilize around that. Agnes, one of the things I wanted to talk to you about in this question, and maybe this is a way to focus it a little bit for you, although feel free to go in any direction you want. It's like so much of your research in the last several years has been on the history of emotions, and I haven't heard enough, and maybe I'm sure it's out there and I'm just too overwhelmed to pay attention to everything, but where's been the history of emotions in understanding COVID, and how can the history of emotions help us right now? And how have you, as somebody who's been steeped into this field and this way of knowing the past, and clinicians and patients and practitioners and healthcare systems from the perspective of emotions, how have you felt continuing to study that and then using it to process this as well? Those are two kind of like sides of a very deep question.
Yeah. I think in some ways your question that was designed to focus it has made it even more difficult, but I'll give it a go. I agree with you, Jacob. I think that it has been incredibly, it's maybe goes to refer to it in these terms, but in some ways it's been a really positive professional experience, because it has been about aligning something that I think is incredibly important with something that everyone else thinks is very important, feeling a kind of a better, and I think part of that is the sort of, I suppose, quasi-political point, is that I do think that one of the things that drew me to the history of medicine in the first place was its sort of promise to problematize and criticize something that is otherwise too often taken for granted, that medicine is seen as this sort of self-evident and uncomplicated good, and a sort of a positive progressive force in the world. I like, the thing I have always enjoyed about the history of medicine, the thing I think is politically important about the history of medicine, is that it challenges that assumption. And I think one of the things that's been, productive about the pandemic in that regard is that I think has exposed medicine and science to people. It has made clear these things that I think historians of medicine have been working with for a while, that, that medicine and science make promises that they can't always keep, and that they are deeply politicized and culturally contingent and socially, embedded, all these things that, if you're a historian of medicine, you're used to talking about. I think that you can't really deny that now, if you've lived through these past 2 years with even a passing glimpse at the news. And so that, I think, is a really good thing. And I think that has equipped historians, or made it easier for historians to engage in these sorts of more public debates. I think, as with all the other stuff I was talking about in terms of like how we deal with and communicate about disease, I think the way that historians have been able to intervene in these debates is also trammeled by the way history has positioned itself in the past, or how it's been sort of positioned in relation to like policy and public discourse in the past. I think history has a lot of professional historians have a lot of work to do, thinking about how to, if we go back to what you were saying at the beginning, right? Like, history doesn't just repeat itself, or, and I think some of that is about public perceptions about history that aren't necessarily entirely within our control, but some of that I do think we have some agency over. And I think I've always felt this way, and it's only been reconfirmed by the experience of the pandemic, that historians should have a voice in these sorts of debates about the past. Not to say, we have straightforward lessons or anything like that, but I think that is, I think historians need to speak to people that aren't just other historians. Not that there's anything wrong with other historians, love other historians, but we need to broaden our audience a little bit. And I think in terms of the history of emotions, I think one of the difficult things about the history of emotions is it also does exactly the same thing that the history of medicine does, or one of the good things, I suppose, is that it also problematizes something that we think of as universal, straightforward, biological, inherent. We think everybody is going to have responded to this, situation in the same way. Everyone is going to have felt about something, that feelings are universal in time and place, that they are, a kind of automatic evolutionary response to settings. And obviously, going through a kind of collective trauma, I suppose, or a collective experience, maybe more accurately, reveals to us, actually, even people that we think of as incredibly close to us, or people who we think we maybe should share a set of an emotional responses or an emotional repertoire with, or whatever, actually have felt very differently about something. And so in some ways, I think, again, the pandemic has been useful in underscoring some of the fundamental kind of theoretical claims of the history of emotions. And I do think that having a richer public discourse about feeling, whether that's when I was last on COVID calls, I was talking about physician well-being specifically, or like how healthcare professionals have emotionally dealt with the pandemic. And I think, that is an area that probably will benefit ultimately from the pandemic, because I do think that it's not a new problem, but I do think it has received greater focus and attention, and a more critical eye as well. So a more kind of critical and concerted effort to make people's feelings about work, more productive, better, nicer. And that obviously applies to work of all kinds. I've just created a volume on emotions and work. And I think, work is obviously something that has been really taken under the microscope these last 2 years, whether that's about reconsidering, what your job means to you, or what you think the purpose of your job, as we are talking about now, how it's changed the way our working lives are actually kind of function, and also how it's sort of blurred those boundaries between the personal and professional in both like physical, literal ways. Everyone's working from home and all that kind of stuff. Well, not everyone, a proportion of the population are working from home, but also in a kind of more, I suppose, diffuse and some generalized sense. So yeah, those are my thoughts.
Those are all really amazing. Thank you both so much. I'm respectful of your time, and I know you both are super incredibly busy. So I just want to thank you both, friends, Nathan and Agnes, for joining me today and being part of these 500 episodes of the first 2 years of COVID calls. And really today was really great because it helped to crystallize for me some of these deeper reflections. And I understand, like, as a historian of public health and disease, that like even attempting this exercise is itself it's fruitful and it's fruitless, because like reflecting on the pandemic today in the last 2 years doesn't bound the pandemic in any real way, but it's an attempt to process. And I think, continuing that process is a deeply important historical one. And I think, like, yes, the metaphor for cancer is a fraught one, but it's one that we can use to help us at the same time. And I think, we benefit from your work so much and your voices and expertise. So thank you both so much. And please join us for the remaining episodes as we get to 500. Thanks, everyone.